Good afternoon, everyone, and welcome to the Melanoma Research Foundation's Ask the Expert series. We are thrilled to have all of you here today joining us for the third installment of our Ask the Expert series brought to you by the Clear2 Initiative and Castle Biosciences. My name is Lauren Johnston, Senior Program Officer with the Melanoma Research Foundation, and I'm so thrilled that you're all here to learn about standards of care for ocular melanoma from Dr. Prithvi Ridhyanjaya. A little bit of information about the MRF and then the month of November 1st. So this month, the MRF's Cure2M initiative is promoting our national awareness campaign, #IGetDilated, in honor of Eye Health Awareness Month. Over 2,000 Americans are diagnosed each year with ocular melanoma or melanoma of the eye. It's the second most common form of melanoma. Getting a dilated eye exam yearly is a critical way to diagnose OM early, as well as promote eye health as part of an annual wellness visit. This month, we're excited to educate our community, and we have several events along with this Ask the Expert series that you're watching today. The MRF's Cure2M initiative will also be hosting our 9th annual Patient and Caregiver Global Symposium next week, November 19th through the 21st. The event will be virtual with both pre-recorded and live sessions. This is a 3-day event filled with helpful information, focused on providing opportunities for education, support, and connection for the ocular melanoma patient and caregiver community. 5 organizations from 3 continents came together to plan and facilitate this event, a first for Cure2M. Some examples of topics include adjuvant therapy, latent effects of radiation, COVID-19 and its impact on OM, an overview of clinical trials, OM research updates, accepting your new normal, anxiety, and more. The 3rd day, November 21st, will be a full day of live panel discussions with our global partners. Education is critical for patients making informed decisions about their care. We are thrilled to partner with Castle Biosciences on the Ask the Expert series, which is touching on topics to help educate and empower the ocular melanoma community. Today is our 2nd session in the series and will be focused on standards of care in ocular melanoma. This session is streamed live to MRF's Facebook page, but will also be available after as part of our video library that you can share at any time. As a medical disclaimer, we just want to encourage people to use the comments section to ask questions, which will be addressed at the end of today's session. The information presented during today's session is for educational purposes, and any treatment questions should be directed to your healthcare provider. We would encourage everyone to visit melanoma.org to learn more about the resources we have available for our OM patients and caregivers. I'd like to introduce our speaker, Dr. Prithvi Ridhyanjaya. He's an associate professor of ophthalmology and the director of the Ocular Oncology Service at the Byers Eye Institute at Stanford University. He is a surgeon who has focused his clinical and academic career to the care of patients with eye cancer. He served at Duke University for 15 years, building a comprehensive eye cancer service. A new transplant to lovely Northern California, he was recruited to Stanford University 2 years ago to build a state-of-the-art ocular oncology service at the Byers Eye Institute. Welcome, Dr. Ridhyanjaya. We're so excited to have you here today.
It is totally my honor. Thank you for letting me be a part of this. It's great to be able to partner with MRF and kind of looking at this month of November, which is so important in terms of cancer awareness in general, but specifically knowing that our community of patients with ocular melanoma have an opportunity to educate their friends and their families about the importance of getting a annual eye exam and to have their eyes dilated. So important. So thank you so much for letting me be a part of this. I'm just going to share my screen and we can get going. I hope this looks okay. Lauren, thumbs up. Okay, great, thanks. So we're going to talk today about standards of care in uveal melanoma as part of the Ask the Experts series. I am a consultant for Castle Biosciences and Aura Biosciences that are related to the care of patients with ocular melanoma. And I would like to, again, thank MRF for coordinating this, but also Castle Biosciences for their forward thinking in trying to promote education and cohesiveness in the community of ocular melanoma patients. So the interesting component of where we are today in terms of deciding what is standard of care is that there's an evolution in the science of where we stand in ocular melanoma. It's ever changing, moving forward at a breakneck speed, and I think that's very important to take into account. How that information actually gets to the point of helping patients and changing how we manage things is why standard of care is an evolving process. What was standard 10 years ago, 2 years ago, may be different tomorrow. So I think as an active group of clinicians and researchers, we realize that we take the best information that we have and then help to define how that can help our patients moving forward. Ultimately, standard of care is trying to develop what we would call personalized cancer therapy. So you take a population of patients that have a certain condition, get information about them at the molecular level. So even beyond the level of the tissue or the cell, but at the actual level of the genes and their functioning. Based on that, you create a predictive model as to what might help us decide where the patient needs to be treated or how they get followed. And then ultimately that information then segregates our patients into various groups, and that may allow targeted therapy. So all of this is an evolution, and we may not have all the steps in this process, but we're working on it. And I think that we will get there probably sooner than we all know. So here is an example of 3 patients that have ocular melanomas, all seen on a dilated eye exam, which you should get done in the month of November. And the question is, we've treated these patients, we followed these patients, but how do we as clinicians then tell the patients to continue to get seen? Now, from your ocular oncologist standpoint, you will need continual follow-up after your treatment, whether it's eye radiation therapy or eye removal surgery, to make sure that first off, your other eye stays healthy, but also that the treatment has been effective and there's no side effects from the treatment. So that's very important that those patients get followed. Now, we also add into this mix the presence of genetic information about these tumors. And we know that these 3 tumors are showing high risk features, such as being class 2 or monosomy 3. So how do we follow these patients? The standard of care in 2020 is broadly defined as the following. At the time of diagnosis, obtaining body scans to ensure that there is no signs of baseline cancer in the body. Generally, that's essentially not found at all, and you might say, should we even do it? But that tends to be the standard that's followed in oncology. Second is discussion on the feasibility of obtaining genetic testing of the tumor tissue to better prognosticate someone being at a high, intermediate, or low risk. And then subsequently talking about getting surveillance body scans to kind of check the vital organs, the critical organs at an interval along the way to see, if anything's turning up. And then using genetic risk to direct that. Now, how do we survey the body? Well, we used to get blood tests, liver function tests, and I think we find that that's not terribly helpful in detecting things early, which is what you want to be able to do, though some doctors still recommend that. But then we use a lot of imaging of the body to try to sort this out. Liver ultrasound, chest x-rays, CT scans of the chest, abdomen, pelvis, MRI scans, or PET scans. If you're to ask me what amongst this list are the most sensitive, highest tech, I think that it depends on your institution because they may have their own specialties, but CT scans, MRIs, PET scans all seem to be very, very accurate for detecting small and early tumors. There may be subtle differences in which one's the best or which organs are being looked at specifically. There is a group called the National Comprehensive Cancer Network, NCCN. It's comprised of recommendations for the prevention, diagnosis, and management of cancers across the continuum of care, from early diagnosis to late treatment. And you can apply their guidelines and findings to nearly all patients living with cancer in the United States. And it's a big deal because their findings influence the standard of care across cancers, and the payers, insurance companies, are all followed by this, and it impacts on what services get covered. And more importantly, it equalizes the landscape for our patients because they look at various categories of evidence and consensus. Category 1, 2, 3, basically using all the best clinical trials and data available to be able to put it all together and then give a comprehensive consensus recommendation. And the great news is, as of last year, uveal melanoma is now included for the first time as part of the guidelines. And we have to thank Dr. Kumar Rao from Washington University of St. Louis and Miguel Maturin, my good friend at Duke University, who are the ocular oncologists that have been tasked to be on this committee, along with some great medical oncologists as well. So all of this is available online, but bottom line is what they've done is they've taken the clinical pathway that patients and doctors go through. They're, from the time that they are first diagnosed in the clinic, stratifying the clinical features, and then talking about the specifics of the treatments that are generally recommended. But what's really important is that they've taken into account clinical, but more importantly, genetic features of your tumor and put it into a stratification system of low, medium, and high risk. And they've kind of bumped up even more so the role of gene expression profile testing and chromosomal testing, which is monosomy 3 or disomy 3, and then have provided a stratified method of screening and surveillance after the tumor is identified. So why is this good for patients with uveal melanoma? Well, it puts a voice at the table for ocular oncologists, medical oncologists, and radiation doctors, and it incorporates evolving science into these recommendations that are constantly being updated. And it equalizes the playing field that creates essentially a standard of care for patients. What do we do here at Stanford? Well, we individualize the treatment for our patients, and we take into account the genetics, but also clinical features and patient preference. And we say low-risk patients typically get scans yearly, and that's done for about 5 years, maybe longer. Intermediate risk patients, which are class 1B tumors or larger tumors, may get scanned every 6 months initially, and that might move to yearly. And we extend that to 10 years for those patients. And high risk class 2 patients are getting scanned, and that's incorrect. It's not yearly, but sometimes every 3 to 4 months. And that's done yearly for at least 10 years in those cases. There was a study that was performed recently that looked at kind of the paradigms of how intensity of surveillance varies based on the type of tumor the patient may have. In general, before the availability of the DecisionDx-UM test that tells us class 1 or class 2, which is the only CLIA certified or federally certified test that can be performed, patients had a diagnosis of melanoma. They're given a certain percentage off the books, and they were kind of screened at relatively high frequencies. Now what we do, I think, is dependent on the genetic testing, and that testing result helps us define patients with a low risk, getting low intensity screening, versus higher risk, getting high intensity surveillance, with the thought that if a lesion, heaven forbid, is found in another part of the body, it can then be identified quickly and treated at the very smallest size rather than waiting for it to get to a large size. So a study that was done by Scheffler and colleagues, Amy Scheffler in Texas, is called the Clear2 Study, which is a prospective registry study where they looked at patients that had gene expression profile testing from their uveal melanoma. They were defined as either class 1 or class 2, and they looked at the physician patterns of testing based on the genetic result. And what they found is that the percentage of patients that had referral and treatment after their gene expression profile testing was greater and done by medical medical oncologist if they had the higher risk class 2 genetics. So if you had class 2 tumor genetics in this population, they were more likely to get referred to a medical oncologist, and they were screened more aggressively. And the types of testing varied across this multi-center study. If you had class 2 testing, they tended to perform tests much more frequently, every 3 to 4 months, compared to class 1 tumors that were tested every 6 to 12 months. The role of liver function testing, the blood tests, were actually pretty low in patients that had class 1 and class 2 tumors. So this was very informative of what's actually happening across the way. And this information has been reproduced and is consistent in several other studies by colleagues across the country. But the bottom line is that if you have a low risk tumor, in fact, managing those patients with a low intensity surveillance plan seems to be appropriate. Patients with a high risk tumor or class 2 tended to get managed by medical oncologists so that they can be at the forefront of diagnostics and therapy, and were managed in most cases with a high intensity surveillance plan, which meant more frequent testing. So I think that this tells us that standard of care has been established, is evolving, but is also validated now by studies. And I think this information guides other clinicians that are dealing with our melanoma patients. We're going to learn a lot more about the role of genetic testing. We are part of the Collaborative Ocular Oncology Group study number 2, the Coug Study. This is headed by Dr. William Harbour at University of Miami, and it's a 25-center study that's looking at the next generation of genetic testing markers. I'm honored to be on the executive committee, and I'm the head of the data surveillance component of this study. So we're learning a lot by this very instrumental trial. So standards of care continue to evolve. It takes collaboration between doctors, researchers, and conversations with our patients. And I think that's the most important thing, to include everyone into this conversation. And hopefully, as science improves, we can make better decisions and better guide the care for our patients. So that's all I've got. I'm going to stop sharing my screen, and thank you for this great opportunity. And maybe there's some questions.
Yeah, thank you so much again, Dr. Mruthyunjaya. It was very informative. I think that a lot of us didn't realize the NCCN standard, so that was fantastic. So thank you so much for including that.
I'll also put a little shout out that Dr. Susan Sweater from Stanford, a dermatologist and a melanoma expert, is also the chair of the entire NCCN melanoma group, and she's a great she understands uveal melanoma, and she's a great advocate for our ocular melanoma community. So we have friends in high places. So it's good for all of us.
Yeah. It is. So we do have just a couple of questions to start out with, if that's okay.
Sure.
So the question being, how long would you say that it takes to establish the standard of care? Are there other disease areas that OM have modeled themselves after, or can continue to model themselves after, to kind of expedite that process, or really start honing that in more for the ocular melanoma?
That's a really good question. So ocular melanoma, obviously is not as prevalent as other cancers, where you have just a mass of people that are unfortunately, afflicted by conditions that really push research and push information and collaboration. So I think that's one of the keys. In the past, I think that there were few centers in the country that really set the standard. But now that as we have more and more experts across the country, but more importantly, better science, better diagnostics, better studies, more of us involved in these studies, I think that makes a huge difference in the culmination of that information to be able to impart change. So standards of care can take decades. It could take years, but I think science is always wary about jumping too far ahead to say that this is the answer. I think the big biggest change has been in the role of genetic testing, which has helped to identify high risk and low risk populations. The next era of this is using that genetic information to then lead to targeted therapy or personalized therapy. And that's going to be the next step. But that will take some time to establish that into what's truly standard of care. In terms of examples, I think a lot of fields in medicine and oncology do a great job with this. Breast cancer, lung cancer, have much more targeted therapeutics than even cutaneous melanoma. But even in skin melanoma, there's so many more options today than there were even 5 years ago. So these all evolve. Put it this way, the fact that NCCN feels that there's enough information to establish a uveal melanoma section means that the data is there to be able to guide folks across the country.
Which is exciting to see this rare disease included in these standards. And I think that it only just, like you were saying, like it's pushing us towards this targeted therapy piece, like we're on the cusp of something, which is exciting for the community. Another quick question we had is that, so some folks are seen not at large academic centers or medical institutions that have the specialty for someone who's been in ocular melanoma. So in regards to that class breakdown, when you were discussing the rate or the length of time between scans or between surveillance, how do you recommend someone advocate for that surveillance piece that you were bringing up earlier in your presentation?
It's a good question. I think that some of that information is still in the evolving standards of care, and it may not be obvious or one resource for it. I think the NCCN guideline is a kind of a universal every person's document that medical oncologists will understand. So I think first and foremost is to have a conversation with your eye cancer specialist, your ocular oncologist, and kind of figure out from their standpoint, what is their recommendation? How do they feel? And sometimes that information can then be forwarded to your either internist who may be doing these scans or your medical oncologist who wants to do the right thing, but just may not have seen many patients with this rare cancer. So they might be applying other standards of care that sound good to you. And that may not be wrong. It may be too much, maybe too little, but the NCCN is a pretty good document that they would know and kind of have handy. The other option is always to get a consultation with a medical oncologist, who is familiar with ocular melanoma. So maybe at the institution that you were treated at, that information can then be transferred to your local specialist, who can then follow those recommendations. I think it's not so easy just to take something off the shelf and say that this has to apply to me. There are always patient level decisions that come through, but if there's a plan and then an understanding of how to execute that plan, I think that it's very reasonable. But you have to be your own advocate, and I think that your ocular oncologist definitely, as I know everyone across this country doing it, will be your advocate too. Sometimes it's just getting that information to the medical oncologist that may not be as familiar, but I think they're in it with you. So I wouldn't be afraid to discuss.
Okay, wonderful. So really just pushing that, bring it up, be your own advocate, make sure the information is getting to the appropriate individuals on your medical team, so that they all come together for that standard of care. Really.
I think some of the issues are that patients don't know, what tests to get, how often to get them, and when to stop getting them. And I think some of that conversation comes down to what is the medically right thing to do. Second is just accessibility of getting tests. Insurance issues kind of come into it. And then finally, just the patient's willingness to want to do it. I have some patients that will do as many tests as we tell them to do, they'll do it. But others are like, you know what, I don't really want to do more than I absolutely have to, or any at all. And I think that sometimes it's a conversation and it's a negotiation, and it's all for the same good ending. But I think we do customize it, personalize it, I think is the better term.
Wonderful. So we do have some questions from the audience. So the first one is, we had an individual who, the question revolved around if you hadn't been able, or if you weren't able to have the genetic testing done, should that individual be monitored more aggressively, since there's no class to really determine the 5-year outcome that the test usually assists with?
Great question. So there are different scenarios in which patients do not know the genetics of their tumor. First, they may have been treated at a time when that testing wasn't as available. Number two, the risk of getting that information from a particular eye might outweigh the benefits. So from a safety standpoint, it wasn't offered, usually for very small tumors. Or the physician who's treating wasn't comfortable with obtaining that biopsy, and that can happen. In that case, we default back to what we know about clinical features, the size of the tumor, its location, the rate of its growth, how big was it essentially, and then we can then stratify with information we have from other sources, and NCCN does help us with this too. So again, that document can be kind of a guide. I would take someone without genetic information but has a much more aggressive appearing tumor and err towards treating them as a higher risk. Ones with a lower risk tumor, I would then err on treating on surveilling them as a lower risk patient. But again, I think it does come down to just knowing. On average, it may come down to about every 6 months. If you're really unsure, then that's kind of like my baseline and my default. But then you can always adjust that as we go. It doesn't mean that you shouldn't get surveillance if you haven't had genetic testing. It just might mean that you have to, again, personalize it to your specific situation.
And another question regarding just the surveillance piece, which you briefly touched on in your presentation, is just the blood work. I think that there's some questions around how some doctors really depend on that to determine whether or not it's metastasized. Can you speak a little more to how that affects the overall surveillance for a patient?
Yeah, good question. So I'm never going to say that a test is wrong or you shouldn't do it, but the data tells us that waiting for liver function tests, an indication of if the liver is damaged or diseased, to go up to a point that's detectable may be after the fact that the tumor is actually in that organ and growing and detectable by other means. So I think that there was, for many decades, the standard of care was to get the liver function test. I think now, with how good the scanners are and our ability to find lesions that are just essentially millimeters in size, that's not going to beat. It's not going to get beaten by getting a blood test at this point. Now, in the future, there could be blood tests that might detect the melanoma cells, and that may be different. In our practice, we don't get routine liver function tests anymore, and that's probably been about 3 years now that we don't do that as part of surveillance. But if your doctor does, I'm not going to tell you to fight with them on that one. But I think that it's the data tells us that it's probably not as sensitive.
Okay, wonderful. And then we are going to have just one more question, if that's okay. So in regards to the different scans, I think that there can be some confusion around why someone would ask for a CAT scan versus an MRI, especially, full body versus do they need to focus on the abdomen or do they need to focus on head in regards to brain mets. Do you have just a quick few tips to break down the difference between the two and why one might be used over the other?
That could be our next Meet the Experts session. So bottom line is I rarely get an MRI of the brain or the head because ocular melanoma doesn't go to the brain. It's just very, very atypical. So we don't do surveillance for the brain with ocular melanoma. For the body scans, it depends on your institution. If they're really good with MRI or really good with ultrasound or really good with PET scans, then you go with the technique that they are experts in. In my opinion, MRI scans have no radiation, so getting repetitive MRI scans doesn't expose you to more radiation. It may be harder to get those approved by your insurance. CAT scans are usually quick to get. So my first scan, like when I first meet a patient, I can probably get them into a CAT scan like the next day. The MRI might take a little bit longer. So in my practice, I initially will start with a CAT scan just for ease. And then the subsequent monitoring, especially if we're seeing them every 3 to 6 months in that interval of more intense scanning, we will use MRI scans alternating with the PET scan. That gives us different types of information using the same body as the backdrop as we go forward. So I think it depends again on the patient, their situation, their insurance coverage, and just what we're actually looking for. But all of those are like super fine-tooth combs. So you're not going wrong with any of those modalities in this day and age.
Okay, wonderful. And just to clarify, talking about brain metastasis, I know that you're saying that it's kind of an outlier, that it's not as common as metastasizing to other parts of the body.
Super rare.
Okay, but
super
it can
rare.
happen.
So has it ever happened? Yes, but you're talking about very, very, very rare events that we write up in the medical journal. So skin melanoma, definitely we worry about the brain. Uveal melanoma, it's never say never, but it would be the extreme rare situation to the point where it is not something that we recommend surveillance head scanning unless there's some symptomatology or something very atypical.
Okay, wonderful. Thank you so much. This has just been, I think, one of the most insightful opportunities for well, at least this is our second Ask the Expert, but I think just in regards to...
I'm in the top 2 is what you're saying?
Yeah, absolutely, top 2. No, I think that surveillance can be such a touchy subject, and I think that you've just covered it really well, and just so appreciative of you taking the time and being here for that. So thank you. I can't express our gratitude. And I just also want to thank Castle Biosciences for their generosity in sponsoring this series during our hashtag I Get Dilated Awareness Month. Just quickly before we end, I'd like to highlight just a few resources that the MRF has available on our website. We have information on genetic testing at melanoma.org. We also have an entire section on our CureOM initiative page, and it provides education and resources for newly diagnosed patients, caregivers, and also provides information for ongoing support services, which includes monthly support groups. Just another reminder that our free Global Patient and Caregiver Symposium is next week, the 19th to the 21st. Again, this is free, and registration can be found on our website. Speakers will be presenting on topics for recently diagnosed to metastatic patients, and those experts that will be speaking are from all over the world, which is just really exciting. And lastly, we just hope that you can join us next week for our 3rd installment of Ask the Expert session. It'll be Thursday, November 19th at 3 p.m. Eastern. We will be joined by Dr. Peter Hovland from Colorado Retina Associates, along with a patient family, the Zubek family, and they will be covering genetic testing results and the explanation of those. So we're just super thrilled to have this opportunity to have an Ask the Expert series, and thank you for being our second one of the series, and we hope that we can see you again another time.
Thank you so much. Really appreciate it.
Absolutely. Have a wonderful day, everybody.
Take care. Bye-bye.